connecting. Right ahead, Kate.
All right. Well, welcome everybody to today's Policy Learning Lab webinar. Topic is identifying and addressing food insecurity in healthcare settings. And we developed today's webinar to really be beyond a 101 or like your overview level. And we're really trying today to take a deeper, detailed, action-oriented dive into this work on the ground. And so with all webinars, much of the richness of what you get out of it is triggered by how much you participate and jump in and feel encouraged and invited to participate actively in the question and answer and the discussion at the end. So please make use of the chat. We're going to try to save all of the questions and discussion until the end. A lot of material to get through. So use chat. If you don't want to lose track of your thought, feel free to use the chat, or you can hold your questions and we'll keep the lines open and you can just ask them verbally at the question and answer period as well. We are not going to mute lines centrally unless we have an issue with background noise, so please just either mute yourself, mute yourself when you're not speaking, and remember not to put us on hold because they'll have to listen to your hold music. Teams from the 2019 Policy Learning Lab focused on food insecurity were invited to participate in the call today, as well as the teams that are currently working as part of phase 2 of the lab. And mentioning that at the top of the call, because those of you who were involved last time not be familiar with our presenters today, and I'm going to move on and do a quick intro so you know who all is working on the project at this point and who's doing the presentation. So from the Nemours side of things, you have me, Kate Blackburn, and you have Emily Chaunceo on the line. You can forward. Yep. And then we are continuing to work with Change Lab Solutions. So all of you that are on the call should remember Manel Capagoda and Sarah Bartel, who worked with us in phase 1 of the labs last year. And then new working with us for this round of the Policy Learning Labs, we are really excited to be partnering with the Hunger Vital Sign National Community of Practice. And that community is co-led by Children's Health Watch and FRAC. So to our presenters are Rich Sheward, who's our point person from Children's Health Watch, and Heather Hartline-Grafton, who's representing as a point person on this project. So we're really excited to have them working with us and to bringing their resources to you guys. We don't need to go through the Twitter, but I do want to encourage any of you that are social media users to follow our different groups so that you can stay connected with additional resources. And as always, wanted to make sure to mention our funders and sponsors. Before we turn things over to Rich and Heather, though, I wanted to call your attention to the poll that Emily's going to open up for us. We're always trying to think about what topics should bring to Policy Learning Lab teams going forward. And there's 2 groups on my radar is potentially really solid groups for us to connect with, may bring forward for a webinar or a call for those that are interested. One is Policy Link and the work that they're doing in food systems, and then the access database that they have, I forget the exact name. And the other group is for community health and that network. They are really focused on the data sharing piece in community partnerships. That's sort of their main and exclusive focus. And they have a very, very robust, active group that's constantly having, like, I'm getting these daily batches of these really rich kind of in the weeds conversations. So I wanted to get folks how much you know about these groups so that we can take your feedback into consideration as we decide if we want to do sort of small group ad hoc calls with them or if it's worth bringing them in for a full webinar. So that poll should be up and visible to those of you who are in front of your computers. It'll stay for 5 minutes and then it'll automatically close. So if you can kind of do that with one half of your brain while Rich and Heather are starting their presentation, I think that we'll be all set, and we'll kind of take it from there in terms of the results afterwards. If there's questions related to the poll or anything that I said at this, again, feel free to either use the chat or we can talk when we get to the Q&A point. But I want to pass things over to Rich and to Heather to get started because they've a tremendous amount of work and put together what I think is a really remarkable presentation that's really deep in the weeds. So I'll guys take it from here.
Great, Kate. Pat and I are really glad to have the opportunity to present to you all this afternoon. Our talk today is really coming out of the conversations that we've had with each of the Phase 2 Learning Lab teams. So we're going to hit on a number of topics that were brought up on those calls, but then we're also going to cover things that necessarily brought up on the calls but factor into this framework that we've developed for you all. So we've got a total of 75 slides here and not nearly enough time to cover all of the material, but we included it all because we want you to go back to this slide deck again and again as a resource and source of information for you. There are a ton of links, there's a ton of contact information, people to reach out to more about specific issues and topics. So we are going to move through this as quickly as possible, stop on a certain number of topics that were sort of flagged as high importance to you all, and then take questions at the end. We want to make sure we have time for your questions and a good discussion. So here beginning, these are some key resources that we really want to make sure you're aware of. A brand new book that just came out. It's hot off the press. There's a link here to an e-copy that we're making available to you, but I do recommend that you go and purchase your own. It's a great book. There are toolkits from Feeding America in partnership with the AAP and Humana, respectively. A great toolkit from a group in Texas. The Social Intervention Reevaluation Network has a wonderful set of tools and evidence library. And then, of course, others are available for all of your teams on moving healthcare upstream. Okay, so somebody told me recently that our brains can only hold or process 4 things at once. So we've broken this framework down into 4 key actions. Number 1, a case to the importance of addressing food insecurity. 2 is incorporating food insecurity into your institutional workflow. 3, building cross-sector partnerships to address the short and long-term food needs of patients. And then 4, finally, advocating for a strong nutritional safety net. And you all in different phases of this. Some of you are complete all of them and are sort of building, but this overall framework is going to be very, very helpful for us as we move forward. This is the more detailed version of that. Work our way through each of these steps in the food insecurity screening and referral process, with the organizational champion, getting buy-in, identifying that champion, noting who the early adopters are, and allowing them to lead the way for an organization to really dive into this work. The selection of a screening tool, flow, documenting and embedding these questions into the electronic medical record, training and communication being something that's incredibly important. Community sensitivity. I mentioned documentation. Then we move to the actual interventions, so forming community partnerships, fostering those partnerships, and then monitoring and evaluation and systems level action. Now, beginning with the first half, identifying food insecurity in healthcare and community settings. So the management consultant, educator, and author Peter Drucker has this great quote, "Culture eats strategy for breakfast." And at the end of the day, all of this work starts with changing the culture of the organization. As you know, have done this work already, it's incredibly important to have organizational buy-in, to have the early adopters and the leaders serve as role models and in many cases train other staff in healthcare setting to do this work. And so it's really beginning with almost the hardest part, which is changing the culture of your organization. I'm going to make a quick plug for a webinar that's taking place in a few days, led by Rishi Manchanda, who leads an organization called Health Begins. They're going to spend an entire webinar just talking about this, just getting off the ground. Okay, great. So we won't do much time on that.
I'd like to remind you guys to please mute your own lines. We're getting a little bit of background noise. So please mute yourselves. You're not centrally muted. Rich, go ahead.
Thank you. And then here we have selecting a screening tool. What I'm going to do is actually skip forward. There's a ton of great information on this, using the Wilson criteria to decide which tool is right for you, essentially making sure that your tool is evidence-based. You have a wonderful document from Siren on identifying food insecurity, a review of the evidence that's out there. There's also a number of slides on looking at how food insecurity is incorporated into a larger social determinants of health or health-related social needs tool, or in some cases screening tools, and what the bigs are and how it looks and how it takes shape, and how you can sort of choose between these and make the right choice for you. We're not going to dive into selecting a screening tool right now because many of you have already done that. You're already screening and you know what you want to use and you're using it. But I think helpful information and information that we wanted to make sure that you had available. So I'm going to kind of skip past that part and move on to developing flow. So it comes from the American Academy of Pediatrics. And again, I know many of you are not pediatricians and don't work in pediatric healthcare settings, but this workflow planning set of questions are, I would say, applicable to really any age group. It just happens to have come from the American Academy of Pediatrics. And these questions about should are using a verbal, electronic, or paper screen, and how do we consider our patient population, which patients to screen, and which staff are going to do the screening, and where is this going to take place? So these are 16 questions that I want to share with you all. I find extremely helpful when developing your workflow. And many of you mentioned the interest in understanding how does training take place. In many cases, there are opportunities to take advantage of continuing medical education credits, and our track actually partnered with the AARP to put together a 1-hour module. I'm going to let Heather explain a little bit about this. Again, I'll just hand it off. Heather, you can jump right in here.
I think we can all agree that engaging and training staff is critical to this work, and we know that that the healthcare community is well positioned to identify food insecurity, to help address food insecurity, but many providers don't have the knowledge or resources they need to be effective, comfortable, or successful in addressing food insecurity. We at FRAC hope to close these gaps in a number of ways, and one of which is a training opportunity that's here on your screen. So in partnership with the AARP Foundation, we launched a free online course earlier this year that targets healthcare providers and community-based partners working with older adults. This slide here shows the title and opening screen for the course, as well as a URL for the course. This course, as we see here, older adults refer to adults 50 years of age and older. The course takes about an hour to complete, and again, it targets healthcare providers and community-based agencies working with older adults. But I do want to stress that a lot of the information and strategies are relevant across the lifespan. We start the course by defining food insecurity and describing the various consequences of food insecurity, and then we talk at length about the how-tos of screening and intervening. And I also want to emphasize that the course has been approved for continuing education credits, so this might be a nice incentive for some of you or the professionals you work with or want to work with take the course. The course also includes a number of downloadable resources, including posters and charts that can be readily used in clinical and community settings, and some of these can also be, you're able to edit the document so that you can make or tailor the information to your own community. Finally, throughout the course, there are a few interactive knowledge checks and activities that can help learners better understand and retain information. So next slide, a screenshot from the course. So we developed a number of patient-provider scenarios to better equip providers to address patient concerns or barriers related to SNAP. So scenario here, for example, the patient Richard is a little hesitant in applying for SNAP because he doesn't feel comfortable accepting charity or welfare. And potential response for the healthcare provider is offered, including HAP isn't a handout, but it's a program that can help the patient purchase the food they need to be healthy and independent. So that's just one example of a screen from the course. I encourage you and your teams to take the course and promote it widely because I think it serves as a really useful training resource for professionals. And the website for the course is at the bottom of your screen here, so seniorhealthandhunger.org. So I'll leave back over to Rich.
Thanks, Heather. So that's just one resource on staff training. There are other resources out there. Those list of key resources have a wealth of information within them that can go a little bit deeper and provide even more specific examples and resources available to you. Patient and community sensitivity was another topic that was flagged by some of you to focus on, so we're going to take a little bit of time to discuss that. And again, it's why staff training on food insecurity and the use of screening tools and the sensitive communication of this is so essential. To ask two questions in an office visit is simple in concept, but in practice, as I'm sure many of you have figured out by now, it is actually a little tricky. And so patients and even providers might be uncomfortable discussing food insecurity. And so practices should take steps that can create an environment where patients and providers are able to comfortably discuss food insecurity. And this is by bringing it out into really the open, that this isn't necessarily a thing of shame, that this is something that you ask all of your patients. And this is an example, a partnership between Hennepin County Medical Center and Second Harvest Heartland. What you see on your screen is a flyer that was made available to all patients on how Hennepin County Medical Center is taking steps to improve food security. And when a patient does screen positive at HCC, what they do is they receive consent from that patient so that they can then share their name and phone number with Second Harvest Heartland, which is their community intervention partner. Second Harvest Heartland receives this. Talk more about this warm handoff later on, but Second Harvest Heartland receives this information. It applies with HIPAA, and they are able to reach directly out to the patient. So we're saying, to make sure you have a welcoming environment and make sure that you receive consent before sharing any information with those community partners. We want to make sure that the patient wants to receive help regardless of their screening result. HIPAA compliance. There's a great resource from the Center for Health Law and Policy Innovation at Harvard Law School and Feeding America. There's a link to it, and I'll also just make a quick reminder, many of these slides, the sources, the source information, the actual documents that we're referring to, we have these short links here on the screen. We have contact information so that you can speak with the authors. They've got a great resource online. It's a full report on how to comply with HIPAA. Another why that warm handoff is so important and why it's important to be sensitive to the community and the community's needs to meet them there are is this great example that you might have seen because it's a few years old now of Permanente in Colorado and their partnership with Hunger Free Colorado. At first, they had a passive referral system where they would provide a paper sheet of resources that the patient could access to meet their food security needs, and then a very low connection rate. We began this electronic referral program to Free Colorado. We were able to increase their connection rate by a huge margin. And really that speaks to the onus on patients to make that connection. Many of them already lead very stressful lives. Food insecurity is economic hardship, and to make the gap between talking to the provider about food insecurity and then actually getting in touch with a resource, make that as easy as possible, and to meet the community where they are is incredibly valuable and important and successful. So we're, diving a little bit to the warm handoff conversation, but it does tie into community and patient sensitivity. Okay, and then moving on to documentation. So making sure that the questions are vetted in the electronic health record, and that feeds into both the tracking process, the screening process, the tracking process, even research. It makes it all much easier. But there's a lot of questions out there on how to do this the right way. Many of you use Epic, and questions about Epic and Healthy Planet, I've got listed here a great contact, Steph Orlano, who's very, very helpful around these types of questions. What I do is sort of switch gears again. Vital Sign National Community Practice put together an issue brief of the existing and emerging opportunities for documenting food insecurity screening and intervention, and even billing each part of the visit into a single guide. Unfortunately, we don't have time to go through all of the sides and processes by which you can use your EHR for food insecurity screen intervention, but there's a link to this guide, an email address for the lead author. So if you have any questions on it, you can contact her. The guide itself, that's available online. Also, contact information for Heather and myself. And so we hope that this is another resource that you can use when it comes to documenting EHR. So now to wrap on identifying where to focus on addressing food insecurity. This boils down to those community partnerships, what responding to a positive screen means, and fostering cross-sector partnerships. Children's Health Watch and America on Track put together a great guide recently that sort of lays a good lay of the land on this. I'm going to pass it over to Heather again, who can share a little bit more about this guide.
So as Rick said, I'm going to walk you through this a little bit. On the next slide, you'll see that we identified 4 key actions in engaging our healthcare providers and community-based organizations in addressing food insecurity. And the first action that we show in the guide is the importance of making the case. Of course, to educate the healthcare community and service providers, as policymakers and decision makers, that food insecurity is the social determinant of health that may be contributing to existing health challenges or that can put people at risk for future health issues. So first key strategy in this guide is the second key action is incorporating food insecurity screening into the institutional workflow. And we know it's critical to identify patients or clients at risk of food insecurity. We talked quite a lot about this already this afternoon. So focus a little bit more on action 3 on the next slide. Once patients are identified as at risk for food insecurity, it's critical that they be connected to nutrition programs like SNAP, as well as emergency food providers, congregate and home delivered meal programs, and other community-based resources. So action 3 highlights then implement programs and partnerships to address patient needs. And I think here what we want to emphasize is the need to address both short-term and long-term food needs. So the term need may be addressed through an on-site food pantry, while the longer-term need can be addressed through SNAP or school meals, for example. And I'm going to talk a little bit more about Action 3 in a minute, but I want to get on to Action 4, the final step in our guide, and that highlights the importance of engaging as many people as possible in educational efforts and advocacy efforts in the nation. And I'll talk a little bit more about that later in the presentation. I want to elaborate on Action 3 on the next slide. So building programs and partnerships to address short and long-term needs can take many forms. This slide shows how partnerships can range from passive to active. So passive is on the left and active is on the right. And there's some more background noise, so if you can mute your phones, that would be really helpful for the rest of the webinar. All right, thank you for that. So then if we look at this screen, we see that on the far left, what we call an awareness approach. So in this model, a patient is perhaps given the contact information for a local community-based or social service agency for assistance. While this model approach requires minimal effort for a healthcare provider, we have evidence that this approach is not as effective as other approaches. We move on then from awareness to the assistance approach, where a patient consents to an external referral, for example, to a partner organization, such as an anti-hunger organization. And then the partner organization meets the patient in person or by phone to connect them to resources. So this is much more active than the awareness approach. But if we go all the way to the right, we have the alignment model. Here, patients are referred to sometimes on-site case managers or patient navigators, community health workers, or also to perhaps an external agency. The patients will receive the help they need in accessing programs, including being screened for SNAP, or they may be referred to an on-site food pharmacy. And I think what's important here is the importance of the two-way communication on referral and outcomes and follow-up, so that all parties involved are really being responsive to the needs of the patients and communicating what's going on to one another. And so hand things back over to Rich to continue this discussion on community partnership.
Great, thanks, Heather. And I do want to stress that this approach, this passive to active, it's really not to convey that one is necessarily better, or if you're focused on awareness that you're not doing it right. It's really the wrong door. Everything is doing nothing. And what we're looking at is really just an increasing level of complexity and alignment between healthcare sector and the social service sector. And so to provide handouts, to provide tailored handouts, even if they're in partnership with another organization, like Alberta, for instance, it is still meaningful work. The goal, I would say, is to reach that total partner alignment where there is a agreement and a partnership, and there's two-way communication, and there's follow-up, just to really ensure that that patient's needs are fully met. And one way now to go a bit more into detail on the closed-loop referral process, sort of, is, I would say, attainable for most organizations. That's a step above the resource handout type of intervention. It's something that I have two examples to share, either two relatively, in quotations, simple approaches. One I described a little bit, the Head County Medical Center, and second, Harvest Heartland Partnership. Another one is between Cambridge Health Alliance and Project Bread, based in Cambridge, Boston, Massachusetts. So we're looking at the electronic referral form that is in the HCMC medical record. What happens when this is sent to Harvest Heartland? It arrives as an auto fax. It arrives in your email inbox at Second Harvest Heartland and have a team of outreach workers who provide immediate, well, first of all, they make 3 attempts to contact the patient. And if 3 attempts and contact is not made, then that's noted. If they're able to contact the patient, they offer emergency food resources because they're one of the largest food banks in the United States. They also do over-the-phone SNAP application assistance. It pretty much ends there. They don't provide communication back to County Medical Center, but that is something that they are working on and want to achieve. The partnership between Cambridge Health Alliance and Project BREAD is very similar. So Cambridge Health Alliance is screening. A referral is built into their electronic health record. It generates an auto fax that is sent to a secure email inbox at Project BREAD. And BREAD has a hunger hotline, which has existed for a number of years, but now they're incorporating these electronic referrals into that work so that they as well make 3 attempts to contact the patient. They have name and phone number. They offer them a number of resources that are available in the realm of food assistance. They also do SNAP application assistance. And I think what is the kicker here with this partnership is the Department of Transitional Assistance in Massachusetts, which is the state agency that administers SNAP, provides funding for reimbursement to Project BREAD for SNAP application outreach. So there's a built-in funding mechanism that allows Project BREAD to take on this influx of referrals. That's a big challenge that a lot of organizations face, especially on the social service side. Can we potentially large influx of referrals from healthcare partner or multiple healthcare partners? So that's one way that they've sort of skirted around that problem. There may not be an option in many places, but that's what is working for them. And there are ways, and we'll talk about that in a moment, to deal with the financing of all of this. So, and we'll talk more about this in just a second. Other options out there besides these autofax type electronic referrals. Our friends at Siren in November will be coming out with a very useful guide on electronic referral platforms. So there are companies like Aunt Bertha and NowPow, HelpI. There's a number of them out there. Siren is putting together a really useful guide on taking stock of this landscape. Who are the providers? What do they offer? What is used for the healthcare side? What is useful for the social side? And this will be the first sort of guide or source of information on how to understand these new and emerging services that are becoming available. Okay, so regardless of whether or not the food insecurity intervention that you are implementing takes place within the 4 walls of your clinic or facility, providers should also consider community-engaged approaches that will develop and sustain authentic long-term community partnerships with agencies and organizations. And this level of engagement and collaborative work around shared priority areas should include the presence of shared values, mutually defined strategies and partnerships, and a shared respect and inclusiveness, equal power sharing, and the possibility of mutual benefit. So these partnerships that move beyond simple referrals and focus more on how a multidisciplinary team can work together to develop and implement innovative collaborative efforts that meet community-unified needs. So if you are a clinic that has access to community health workers who can spend a great deal of time and energy bridging the gap between the healthcare provider's office and families' homes to assist them to meet their needs, then that is a very robust approach. If it's the case that you don't have the access to community health workers or a robust social work team with caseworkers, these based referral platforms that I mentioned a few minutes ago also act as an intermediary between the clinic and the community partner to the gap for clinics that aren't able to have the staff support needed and will use robust closed-loop referrals. So this here is the dilemma: do we buy it or do we build it? If you have resources and you have the staff, then by all means, I would say that you build the team-based approach to developing these partnerships with community agencies. If you don't necessarily have the ability to do that, but you can or are in a type of network that gives you access to buy it through working with these EHR-based referral, well, EHR-based, some operate on own source, they're web-based referral platforms. I mentioned on Bertha, Healthify, HealthLeads One, NowPow, Unite Us. There's about 11 that will be covered in this upcoming Siren guide. Is another option. So this is really the dilemma that you are faced with at the organizational level, and it's not that one is better than the other. It's just sort of the way the scenario typically shakes out. I'm going to talk a little bit about what I see as the bigger picture solution to moving beyond the buy or build it. And this might not factor into the decisions that you make at your own institution, because this moves beyond individual institutions and moves into more of the like healthcare sector, social services sector. So as you all know, healthcare and public health, social services, they're all funded in different silos, different funding requirements, different collection and information systems, and inherently these silos make it difficult to coordinate efforts. And it's hard to assess their impact across sectors, which is also important to securing funding to do this work in the first place. So there's a chicken and egg problem there. So investments in one sector can affect outcomes and generate cost savings in another. Leaders really they only consider their own investments and benefits, which is known as the front pocket problem. And so what has taken form in a few different models and seems to be where financing trends are headed is this idea of the hub and spoke model. And to learn more about what these different models look like, I added a few links here. So there's the Healthy Communities Funding Hub model. There's a great article in Health Affairs that sort of defines what this hub and spoke model is and looks at ways of approaching it. One way being the healthcare provider is the hub, and community agencies, the social agencies, are spokes, and the healthcare provider is not only the one that's making the referrals, but doing the financing and committing community benefit dollars to that and providing reimbursement to the social service agencies for serving this population through those referrals that they receive. Another sort of the flip of that is looking at hub and spoke, where is a community service agency that is the hub, and healthcare is one of the spokes. So look at it. There's another article that was in Health Affairs this year, the Balanced Portfolio Model, looking at the concept of it and the experience in the state of Vermont, which developed a series of accountable health communities, really what gave birth to the large currently operating CMMI Accountable Health Communities model. So it existed previously in Vermont, and the architects of that authored this piece, and it describes in great detail the impact approach to the work that they've done and the way that this is financed. And this really, again, to be in Health Affairs, an article on the social determinants as public goods and a new approach to financing the investments in healthy communities. So this moves beyond what individual organizations can do and focuses on what the environment, the sectors can do to really break down these silos and make this work as sustainable and sort of able to finance in a way that's beyond, just a simple referral to a partner. Partner provides a service. It's focused more on the large picture. And again, I want to point you all to these really helpful resources. Much of the information that we've shared in these slides come from these resources. There are other resources obviously in slides, and there are links to those as well. But you all to check these out. They're very, very helpful. Them do focus on how you address food insecurity in healthcare and community settings. Okay, and then lastly, we have the monitoring and evaluation and the systems level action. When it comes to monitoring and evaluation, this really gets down to how measuring success. What are your evaluation models? Are you able to look at return on investment? There's very little out there currently on return on investment of this work, especially around food insecurity. There's some around addressing homelessness among individual adults. You want to consider the user experience and feedback of the patients themselves, quality improvement work. Essentially, the evaluation also gets into providing more research and data, which is honestly sorely needed to understand the impact of food insecurity screening on health outcomes and even food insecurity levels. This is something that has moved behind and been outpaced by the influx of food insecurity screening work that's taken place in the last few years. Not necessarily a bad thing, but we always do need more research. So monitoring evaluation is incredibly important. And the goal is to help us move towards achieving triple aim of healthcare. And that I recommend, if you want to speak to learn more about this or ask specific questions, I mentioned Rishi Manchanda from Health Begins, a great resource of information, as well as Emily McGrath from Humana. She has done some really great work on food insecurity screening and looking at what those outcomes are and how you measure outcomes and success. Moving on an evaluation, I hand it back over to Heather for our final piece, which is about addressing the root causes and focusing on policy advocacy.
Thanks. So there have been some really exciting policy and system level changes that happened in the past few years. To start in 2015, the American Academy of Pediatrics released a policy statement recommended that pediatricians screen for food insecurity and intervene accordingly. And I can't stress enough how important and influential this policy statement was in elevating the issue of food insecurity to healthcare providers, especially pediatricians. And other medical organizations really look to the AAP policy statement as a guide or model in their own efforts around addressing food insecurity and other health-related social needs. And the AAP recommended that pediatricians screen for food insecurity and intervene accordingly, and they also recommended that pediatricians engage in advocacy efforts around food insecurity. And Rich, if you could go back to the slide with the AAP toolkit. Because in order to assist pediatricians in meeting these various recommendations, we at FRAC partnered with AAP to provide a variety of tools and resources to help pediatricians and their practice teams. And so we collectively refer to these tools and resources as Addressing Food Insecurity, a toolkit for pediatricians, which Rich shared earlier on some of the resource lists. So on the slide, you'll see information about the Everyone Project. So there's been a lot of exciting work beyond AAP as well, and I think one of the most notable is the work of the AAFP, or the American Academy of Family Physicians. They recently launched their Everyone Project to help family physicians on actions related to addressing health disparities and other health-related social needs. And some really great resources and tools for providers, including a brand new neighborhood navigator tool that can be used at the point of care to connect patients to resources and programs in neighborhoods. And next slide, I wanted to address something I brought up earlier. I had touched briefly on the importance of advocacy. And anti-hunger advocates like FRAC really need the voices of doctors and nurses, dietitians, and other healthcare professionals to really send a clear and compelling message that food insecurity is a health issue and that we really need policy changes like improving the federal nutrition programs, to help in addressing food insecurity. So part of our AAP toolkit, we developed some specific strategies for pediatricians to support and advocate for national and local policies that will increase access to healthy, adequate food for children and their families. So, for example, the first advocacy strategy is for healthcare providers to write an op-ed or a letter to the editor. Other action is for healthcare providers to meet or otherwise communicate with their congressional representatives, to appeal directly to members of Congress to offer expert information. The toolkit provides much more detail on these strategies if you're interested in learning more. And of course, many of these strategies can be applied to healthcare providers working with adult and senior populations as well. In that slide, you'll see a screenshot from a relatively new resource from Children's Health Watch. Both Children's Health Watch and FRAC, so Rich is from Children's Health Watch, I'm from FRAC, just as a reminder, and our organizations have developed a number of resources to highlight the effectiveness of the federal nutrition programs in improving the health and well-being of children, adults, and seniors. And this type of information can really help equip the healthcare community in their advocacy efforts. So this slide highlights some introductory information on SNAP, and this slide highlights some of the health benefits of SNAP, which include increasing food security for children and their families. As we were preparing for this webinar, one of the teams brought up a concern that their patients receiving SNAP are still screening positive for food insecurity, and I just wanted to address that briefly here. And I think, and Rich, in my view, there's probably three main factors that contribute to this. And the first is that SNAP benefits are inadequate. There's a lot of research demonstrating this, and a key advocacy effort is focused on improving SNAP benefit levels. So while connecting at-risk patients to SNAP is critical, inadequate benefits limit the program's ability to do even more to improve food security and health. Another factor is that Hunger Vital Sign and other tools that screen for food insecurity are just that. They're screening for food insecurity. They're not able to account for the severity of food insecurity. So someone's food security may be improving in part because of the SNAP, but the screening tools are limited in their ability to detect such changes. So the tools identify someone who moved maybe from food insecure to food secure or vice versa, but the tools do not let you know if someone who was food insecure is perhaps a little bit better off than they were before. And then finally, I think another issue to this issue of SNAP recipients still being food insecure is that it just demonstrates the need to screen for other health-related social needs so that patients are really accessing the full range of resources available to them. This can help ease financial strain and increase food budgets. On the slide here that Rich is showing, I just wanted to highlight that while SNAP is the largest of the federal nutrition assistance programs, we also want to promote the effectiveness of the child nutrition programs and advocacy efforts. And here are some resources we at FRAC developed about WIC and school meals and other programs. And both FRAC and Children's Health Watch have many more resources on our respective websites about these programs that can be used in practice as well as an advocacy effort. So that concludes our presentation and the material we wanted to cover today. We covered a lot of material, but are eager to hear any questions that you have for us. So for your attention.
Wow, that was absolutely tremendous. This is Kate. I have pages of notes and questions and things, but let's open it up to the team members that are on the call. And questions in the chat, but you guys can just unmute yourselves and ask. I know it's always a bit choppy being on a bunch of people on a webinar, but we'll see if we can make it work.
I have a question. This is Lisa from LA County Department of Public Health. Hear me?
Yep.
Okay. I was just making sure I wasn't still muted. So I think my primary concern, we're doing a lot of food insecurity screening with some great leadership here at so we joined forces with the Department of Health Services and the Department of Public Health. And my primary concern, because we're also working with some partners here in LA, is that we keep talking about, you know, just screening. Well, but we don't talk about modes of administration. And I think that we really need to look at the literature and really think through this piece. Because I worked in the medical school at UCLA before I took on this job in public health. And we did a screener for sensitive health behaviors. And we looked at literature with a team of professors there, and we realized that mode of administration was critical for sensitive behaviors. And a lot of the literature points that the best mode is self-administered computer-based. Well, sometimes we don't have the luxury of self-administered computer-based, but we do have the luxury of self-administered paper-based. And I have to tell you, we screened over 8,000 people on a self-administered computer-based system for sensitive drug-using behaviors, and we got amazing results. And this was in clinic-based settings. Again, this is something that is going to be screened within social determinants. I think that conversation needs to be had, that if we're going to do any sort of social determinant screening, we think about mode of administration, because it really, the reporting is going to be a real issue, especially with what we're seeing with food insecurity. We're seeing that when modes of administration is face-to-face, there's tons of different statistics that we're getting versus those that are done self-administered. So self-administered, those clinics doing self-administered are definitely much higher than those clinics that are doing face-to-face because of social response bias. I think that just needs to be conversation on that, especially when we're dealing with underlying social needs and these social determinants.
Go ahead.
Very helpful. Yeah, very helpful. And there really, when it comes to food insecurity screening and the mode of administration, there isn't a ton of research out there. Colleague Dr. Mariana Chilton at St. Christopher's Hospital worked with some weeks at Children's Hospital Philadelphia, and they also found that self-administered food insecurity screening resulted in higher response rates. I've heard that anecdotally from other places around the country, but I just want to say I completely agree with you. That's something that we need to look very closely and really could use some good research on.
Yeah, I have to say that when we did it with drug-using populations, they did not lie to that computer, but we would test for urines, and they would be dirty. So, you know, they would lie to us, saying, oh, no, I'm not using anything. And then they'd feel more comfortable giving that response to a computer, which was fascinating because it ended up, you know, we asked permission to share it with our doctor, which they allowed us to do. But it's just, you know, we just need to think about this. We're really getting drastically different rates with those teams that are doing self-administration versus face-to-face. So,
that's a really important thing to think about when you're planning workflows and also resources. So really timely for the other teams that you share that too.
Another issue that we're dealing with, just FYI, is, you know, here in California, we have a massive food recovery piece happening. So it has a lot to do with global warming to a certain degree, so diversion of food into landfills. But finding that the majority of food that's coming from these diversion programs are fruits and vegetables or produce. And so there's really now, especially here in LA, an influx of fruits and vegetables that are being donated. So, but we need to really unpack, and this is another piece that we're working with a professor here at UCLA, really trying to figure out from the patient's perspective access points, because they're really not necessarily accessing at pantries because either they're busy. So how do we think creatively, design this with patients or with the beneficiary, thinking creatively on what are these access points? What will help us, because now the produce that we're collecting is actually, there's so much of it, it's going to zoo animals because there's just not enough people that are accessing it. So we're trying to think of creative ways to make the system more efficient, but also coming from that perspective of the beneficiary to brainstorm and problem solve with them on ways that they would access. So that's that we're working through with our teams here.
Really interesting. Go ahead, sorry, Kate.
No, I was going to say I think that is, the getting the family and participant feedback in all aspects is really critical, especially in problem solving something brand new. Are there questions from other teams or comments from other teams? I know we're getting close to the top. We can certainly, you have all of our contact information in this slide, so please, if you don't have a question answered live, follow up with us. If it needs to be a quick phone call or an email, that's fine. But anybody have a question right now? A minute to unmute. So I feel really, Rich and Heather, I want to thank you. I feel like you brought us to this really long buffet table of detailed in the weeds information, sources, resources, toolkits, etc. That I spent time in advance of the call, and we'll spend more time going back to it and looking at the things that you shared with us even afterwards. So I know that you've helped us, provided us with a really solid range of in-the-weeds kind of research materials that we can all continue to look at and figure out how to use them to expedite our work. And I really want to encourage those of you that are on the call to not only reach out if you have specific questions, but also, if there's sort of bigger picture things that you're struggling with, like of all of these materials, I really have this one question, which of these things, where can I find this one thing that I really need, kind of thing, in the resources that we've shared too, to help about your process, even going through everything that's been shared today. Anybody else? I guess one other thing to mention too is that Rich and Heather spoke about Siren's Guide on the closed loop that's going to be coming out soon. Nimble just wrote a paper. It's different than the toolkit. It's a different type of paper than what Siren put together. But we just, we are about to release a paper on closed loop referral systems that highlights sort of elements, recommendations, strategies, et cetera. So I'll share that with all of the teams as a follow-up to this call as well. Top of the hour, I don't want to keep folks. It sounds like if there's questions that came to the chat, I think that people have taken notes and aren't asking questions live. Is there anything, Emily or Sarah, that you're seeing in the chat?
Yeah, one question. I'm pretty sure we're going to send out the slides to everyone.
Yeah, the slides, and we recorded it. So the slide deck you'll get as well as the recording that has the audio plus the slides. Yep. Oh, well, I think that's it for today. I know my hand is cramped. I even saw the slides in advance, and I still got so much out of this and took so many notes hearing you guys go through it live. So I can't thank you, Rich and Heather, enough for putting this information together for the teams. And I encourage everybody to follow up with us with any additional questions, et cetera, that you have.
Thank you so much. Please feel free to reach out to us with any questions.
Okay, thanks, everybody. We appreciate your time.
Yeah, thanks, everyone.
All right.
Bye.